You're listening to Streetside, the Street Medicine Institute Student Coalition podcast.
Hello, and welcome to Streetside, the official podcast of the Street Medicine Institute Student Coalition. I'm Michael Brennan, nurse practitioner, and I'm here with a fellow nurse practitioner, KK Assman from Kansas City. And KK, could you introduce yourself, please?
Absolutely. Yeah, as you said, my name is KK Assman. I'm a family nurse practitioner, and I am based in the Kansas City metro area.
And you have an interesting story to tell, and we'd like to hear it. Many of our listeners would be healthcare professionals, and some would be in cities where there's not currently street medicine, and they think about starting programs. You are the founder, director, CEO of Care Beyond the Boulevard in Kansas City, and we'd like to hear your genesis story. How did you get into this line of work?
Quite by accident, right? So, as we said, I'm a family nurse practitioner, and I've been in healthcare for about 33 years now. Seems impossible, but so I was in nurse practitioner school, and I was volunteering at a soup kitchen, and I was a regular. People kept coming up to me, mostly volunteers, saying, "Hey, this person out there, they're having some problems. Can you go check them out?" I was from the suburbs of Kansas City and didn't quite understand that people don't have access to healthcare. And my question was like, don't they have healthcare around here? And I started doing some research and I realized no. Now, originally, when I got out of NP school, my plan was to move to an island, open a dive shop, and then have a clinic on the side. This is a far cry from that, but that was my plan.
But it is a deep dive you have taken.
Yeah. Literally,
Yes.
this is a dive. But after I started doing some research, quite by accident, we had a group project when I was in NP school, and nobody could figure out what to do. And I was like, hey, let's look at starting a free clinic in a soup kitchen because nobody could figure anything out. So I may have cheated a little bit, and some of my research was done for me with my fellow students. And I really realized that there was quite an absence of healthcare in the area where the soup kitchen was located. And I was like, okay, well, when I get out of school, I think I'm going to start a free clinic. So I started doing a little more research on clinics for homeless patients, clinics for free for homeless patients, and I discovered street medicine. So that's when I really started diving. I went down that road and discovered street medicine. And I wanted to take it a step further. Not only did I want to start a clinic in that soup kitchen, but I also wanted to pair that with a street medicine team to provide healthcare for those who were experiencing homelessness and to have a clinic inside that soup kitchen where so many people were going every week. And my plan was I was on a 3-year plan. So I went to my actual first street medicine symposium 10 years ago in October. And this was before my organization was started. And my plan was 3 years after I got out of school to start our first clinic. I graduated in January of 2016, and in March of 2016, we held our first clinic. So accelerated that 3 years by, I don't know, a few. And that's where it all started. It's kind of a unique beginning, but really kind of lends itself to really how we've grown and developed based on what the needs are in our area.
Well, and that would be my next question then. How you told us the genesis story. Now tell us the development story. You open a clinic in March of 2016. How's it go?
Yep. So the clinic that we started was really only going to be inside that soup kitchen for the first several months because I really wanted to learn about the patients without being on the streets, with really trying to earn their trust instead of like some random person walking into an encampment going, hey, I'm doing healthcare, because we hadn't done that before. So I wanted to learn the needs of the patients. I wanted the patients to learn about us, and I wanted the word to get on the street about us and what we do. So that's really what we did. We started in March of 2016 with our first clinics, and we did that for 6 months. We learned about the people, we learned about what our needs were going to be, what their needs were going to be, and really how to earn their trust. That was paramount in providing healthcare to our homeless patients. And so then we did that, like I said, for 6 months. Our first street night was September 1st of 2016. We went on the streets, still didn't know where any encampments were. So started asking people, and they directed us to encampments. And that's how we got to where we are as far as like going on the streets and having clinics inside of of stationary locations.
Explain that a little bit to me. It sounds like a bit of a hybrid. You have these clinics and street. Are the clinics owned and operated by Care Beyond the Boulevard, or do you rent space? How do those work, those clinics?
Yeah, we very much are a hybrid street medicine team, right? We have clinics that are mobile and we have stationary locations. We piggyback onto everybody for everything, right? We really collaborate with other organizations. We do not own anything other than our vans. We own a few vans, we own a couple of buses, but as far as buildings, we do not own any buildings. We still have clinics inside that original church soup kitchen a couple of days a week. We also have a location that we now go to that we are really the only healthcare team, and we're kind of the collaborators to bring in other organizations. We call it the Beehive. Down
Uh,
below there is a soup kitchen, and then upstairs it's the healthcare team. We have dentistry, but then we also have other organizations coming in doing housing, STI testing, VA, all of those things. So we partner a lot with other organizations, but really what we have learned is that us having a standalone free clinic is not going to bring people to us. We really need to position ourselves in places and spaces where they are seeking other services because healthcare is not and cannot be their priority. Food, shelter, those kind of things are their priorities. And so if we can pair our services with those services, it's kind of a one-stop shop.
do you become primary care providers for your patients? Do they rely on you?
We do. Um, we do. It's not our intention. And, that's a little bit different than some healthcare street medicine teams. Some street medicine teams really strive to be the primary care providers. We do not, but we are, right? And part of the reason why we don't is because we are an independent nonprofit, which is, of course, different than a lot of street medicine teams. A lot of street medicine teams are associated with hospitals, clinics, schools of medicine. So one of the things that, although I love it, one of the struggles with that is we don't have lab services. We don't have radiology services. We are in Kansas City, as we talked about, and we go both sides of the state line. Kansas is not a Medicaid expansion state. Missouri is a Medicaid expansion state, a weakly expanded state. And by that, I mean like they lead the nation in not getting people renewed for Medicaid. So I don't know how best to word that, but really they really are struggling on the Missouri side with their Medicaid renewals. So we don't bill for services, so we don't have those labs and some of those kind of things that the street teams that bill and that are under hospitals and clinics have.
Which then leads to a natural question. If you're not billing and you're not billing Medicaid or at all, how are you funded?
Privately funded. We write a lot of grants. I am also a grant writer. Didn't know that when I started this, had zero clue. So a lot of people ask me why we don't bill for services, and the simple answer is we can't. The reason we cannot is because we are strongly volunteer based, right? So when I started the organization, we were 100% volunteer. In 2021, I had 4 full-time employees. I now have 22 full-time employees. So we've grown a lot, but the base of our employees are not providers. And although I do have a few medical professionals as my employees, we really depend heavily on volunteers to provide the services. Well, CMS does not allow for you to bill for volunteer providers, right? So I would either have to hire everyone, which I can't do because I am a nonprofit and we're poor, or not bill. And so we really don't have the capability of billing primarily because of that CMS law. And I don't mind it.
It's freeing, is it not? Because no one's keeping tabs on how much time you're spending with patients or what you don't have to report out what your visits, correct? Are you using an electronic medical record
Yeah,
to keep track of things?
absolutely. We use
Yeah,
Athena. Athena
yeah.
provides their EHR to us for free. And because we don't bill, Athena actually, if we wanted to bill, they would charge us for a portion of that. But it is free. Our documentation is good, right?
Yeah.
But I don't have to, my providers love it. They don't have to document to the insurance. They document for the patient and for the provider who's coming along behind them. Right? I mean,
Yeah.
this may be exaggerating just a little bit, but like when I was working in a FQHC lookalike, in order for the clinic to get reimbursed for me counseling a patient on smoking cessation, it had to be documented in three different places, right?
Yeah.
Why? Why is that? Why is, it's in my chart. And so we really get to focus on the patient, their needs, and what we're doing for them instead of focusing on what the insurance company is wanting from us.
Fantastic. And I'm curious with your clinics and your street teams, is that wraparound for some of your clients, your patients, like you'll see them in clinic and then follow up with them on the street or send them from the street to the clinic for a follow-up? Is that how it works?
It is. It really it flows. So none of our clinics are appointments. We are completely walk-in. We have 9 clinics a week. Four of those are street teams. 2 nights a week, we have the bus out that goes into places where there are what we call in Kansas City picnics. So there are nonprofit agencies who are providing food to those who are sleeping on the streets, and we join them with our big bus. And the reason we do that is because when I first started the organization, we slung on our backpacks and we went into encampments like a lot of street medicine teams do. But because every night of the week, Kansas City has people out there feeding those who are experiencing homelessness. Nobody was in their camps. We're like, we can't find anybody.
They're
Someone
all at
says,
the
oh,
picnic.
you got to go to the food. And so I quickly discovered that on a night when they're feeding 200 people at the park, my backpack wasn't going to cut it, right? I needed more privacy for people. I needed uh, more access, more equipment, more supplies. So we do that 2 nights a week. And then 2 days a week, we have a small team. And that's generally one of our staff providers. So we have a PA who works for us full time. We have an NP who works for us. I'm sorry, the PA is part time, an NP who works for us full time. And then they generally team up with one of our outreach workers and our harm reduction navigator, as well as a nurse. And so they go out and during the day, they do more targeted outreach. Whereas the night team is kind of bigger, covering more people. Then during the day on those Tuesday, Thursday street rounds, we really do more intentional visits, encampments that maybe aren't seeking food, encampments that are harder to reach, people who are not coming out for whatever reason, and then also follow-ups, medication assisted treatment follow-up, that kind of stuff.
I'm going to give you an opportunity, and I hope I don't put you on the spot too much, to tell a patient story. Is there a client, someone you've worked with in your now almost 10 years that jumps out as a story worth retelling here?
I have a lot of stories over
I'm
10
sure you do.
a
I'm sure
lot of
you do.
stories in 10 years. So I think that I have a couple, and these are stories that I've told numerous times, and they've given me permission to use their names. I won't use their full names, obviously, but many people who are listening to this podcast actually may know the story of Johnny. Johnny, we first came across Johnny in October of 2016. So right after we started going on the streets. And we were during that time, we were actually working out of the back of my husband's pickup. We've evolved, but so we were down on a hill and we had some guy come grab us. He's like, "Hey, there's a guy in a tent. He's really having some problems. Can you guys go see him?" We had never been to this encampment before, so we're like, "Sure." So we grab our backpacks. One of my physicians, and then 2 other volunteers. So we hike up. Pretty sure we hiked 10 miles one way, but you know how that story goes, right? Just a side note, I always have my cell phone on me. I left my cell phone in the truck. Nobody knew the other volunteers' phone numbers. So we were up in the woods by ourselves, the four of us, right? So we go up there to Johnny, and Johnny was having pretty severe back pain. And he had been to two ERs, and he was pretty uncomfortable. We did a neurological exam, and we felt like he had some neurological changes in his lower extremities that we were concerned about. So we talked to Johnny. Johnny had never met us before. And so we tried to get him to go to the emergency room because of the neurological changes. He was like, no, I've already been to two ERs. They said there's nothing wrong with me, so I'm just going to wait it out. So we made a deal. We left him some anti-inflammatories. We gave him a prescription for some Flexeril to have one of his friends go fill it. And we told him we'd be back and check on him the following week. So we went back to check on Johnny the following week. And he had said like for a couple days he was feeling better. He had gotten out of his tent. He was able to sweep a little bit, but now he was incontinent of urine and feces. And we're like, Johnny, this is a problem. Let's go. Let's take you to the ER. So he said, okay, I'll go, but we had to carry him out. We literally had to carry him out of the encampment. So that night we actually had three providers, myself and two docs. So one of my docs went with him to the ER. Happened to be an interventional radiologist. Look, we're completely welcoming for, providers. So he went with him to the ER. And when he was in the ER was like, there's nothing wrong and he can go. And the interventional radiologist very nicely convinced them to do an MRI in the ER. I don't know what was said that night. To this day, I still don't know. But generally, they don't do a whole lot of MRIs in our ERs. I don't know about your ERs, right? But
No.
he had osteomyelitis in two levels of his lumbar spine. He had already withdrawn because while his friends were really good friends and for a few days were bringing him some drugs, they stopped doing that. They were bringing him food sometimes. So Johnny was put in the hospital. He was in the hospital for about a month. And while he was there, we arranged for him to go into a transitional housing from the hospital. We continued with IV antibiotics that we gave him daily. And this was really our first foray into doing IV antibiotics because we weren't doing that, right? Remember, at that time, we had all volunteers. I was volunteering. I was working at a hospital and a clinic, so some of our volunteers were trading off and getting him his medications. So he went into a transitional housing. Johnny then, while he was in the transitional housing, started looking for permanent housing, went back to school. Johnny is bilingual. He speaks Japanese and English. He was Japanese American. And so he already had a bachelor's degree, but he wanted to go back to school to become a drug and alcohol counselor. So he got his degree. Johnny is today helping run a men's reentry program. He does drug and alcohol counseling. He's been off the streets it'll be it's 9 years this month. I'm sorry, October, 9 years, October. He's still an active part of Care Beyond the Boulevard. He's on our board. But it's stories like that. Like Johnny had never had anybody that had really come back to him and follow up with him. And we're like, we're not letting you go. And he's still with us, right? Like he's still part of our team.
What a beautiful story. That's
Yeah.
fantastic. Thank you for sharing the story of Johnny. And that's awesome. He's on your board and doing the work he's doing. I love that when you see patients get sober, go through detox rehab, and then want to give back. And I have a client like that right now that, she's only 6 months sober, but she wants to come back out and tell others it's possible and work with them to support them.
Right.
When you talked about Johnny going to transitional housing, I want to ask you, you all have medical respite. Can you tell us about that? What is medical respite and how did it come into being? And from your website, it looks like it's rather large and you have a lot of capacity. So I'm curious.
Okay. So it is rather large. We don't have a lot of capacity. I'll tell you about that. So medical respite was never on my radar. Kind of like being a street medicine provider, not on my radar, right? Not in my grand plan for life. A lot of what we've done at Care Beyond the Boulevard has come naturally. We've evolved based on the needs of the patients that we serve. the decisions that I make, the things that we add to our program, the things that we add to our services have been added because of the needs of our patients that I see are not being met in other ways. One of the things, and I'll talk about respite in just a second, but one of the things that we do, we have case management. We have a very robust case management team. I never intended on doing anything related to case management, was not my plan. But one of the things I found is that the housing providers do not help people with birth certificates and IDs. They don't follow up with people. They're not in the field. So you have people who come up for housing, but they don't make their appointment, so they're out of luck, right? So my case management team was born out of that, out of necessity, out of, well, nobody else is doing it, so we're going to. All right. So that's really what happened with medical respite. A couple of years into this and all of the things that we've all seen, right? People with fresh trachs being dismissed to the street, people with wired jaws being dismissed to the street, people with peg tubes being dismissed to the streets, right? And we've all seen it. And so I started thinking, like, what is it that I can do? Because this is not okay. And I'm not going to stop the hospitals from doing that, but we need to do something about this. And so then I discovered medical respite because I hadn't heard of it, right? So our medical respite is really, it's a low barrier medical respite, and it is really, how do I explain it? So I call it post-acute care, right? It's post-acute. Our medical respite is geared towards people who need IV antibiotics, physical therapy, wound care, right? All of my patients need help with their medications. All of my patients need a house. All of my patients need shelter. There are shelters, but we really gear our medical respite to patients who have post-acute needs. So that's how this started. It's like, we need to do a medical respite. So I was talking about it for a couple of years. And then in 2021, Kansas City did this thing. Kansas City, in their infinite wisdom, decided that they were going to put all of the homeless people in Kansas City in motels. Fabulous. So we had hundreds of people in motels. They were spread out across 14 motels throughout the metro with no services, no food, no plan, no case management. We're going to do this for 30 days, and then they're all going to be housed and they're all going to have jobs. Guess what? They didn't. It didn't work. But around the same time, another agency opened, they called it a navigation center, and it was an old motel. And the plan for that navigation center was to be a place where people could stay, get kind of more intense case management services. They gave us 2 rooms for medical respite because the director knew that I was trying to figure out a way to do medical respite. And I will go back just a little bit. In this time period, there was a little something called COVID, and we kind of touched on medical respite through COVID, but not really. Like, we were kind of the point person. We had some funding from the states to put people into motels, to let them isolate for 10 days and recover. We didn't provide medical care for them while they were there because I said, if they need medical care, they need to stay in the hospital because we weren't equipped with that. But we did make sure they had food and they had a place to stay for 10 days. So that kind of was like a little bit scratching the surface of it. But so when the Lotus Group opened this navigation center and gave us 2 beds, that was kind of the beginning of our medical respite. The plan was 2 beds for the first year, 4 beds for the second year, and 5 beds after that. Well, because of the hotel initiative, there were some lawsuits between hotel owners and the Lotus Group and things like that. And so the Lotus Care House disbanded. That organization disbanded. The hotel owner then said, he said, we really want Care Beyond the Boulevard to have this. And I said, okay, we'll take it, but it's going to be 100% medical respite. And he's like, I don't care. I just want it to be used for something good. So I said, okay. So in January of 2024, we took over the entire building. The caveat to that is that the entire building at that time was really only 6 beds were usable. This building was built in 1968. It has cast iron plumbing. I don't know anything about plumbing. I'm a nurse practitioner, but apparently cast iron plumbing doesn't last for 50 years. This has, kind of. So it needs a lot of work and it needs a lot of renovation. So in January of last year, when we took it over, we had 6 beds. We don't own the building. Up to this point, the owner of the building has let us stay there for free and he's paid all of the utilities. Now, that being said, we're getting ready to try to purchase the building and then do some renovations. It's going to cost about $8 million to purchase and renovate the building. But when that's all done, we're going to be at 39 medical respite beds. Right now, we're at 15.
Wow. Are you going to be able to raise $8 million?
Well, yes. So
Yes.
about that. So yes, we are. I'm confident that we're going to be able to do that. Our numbers at Medical Respite are kind of impressive. So what we've done is we built a team at Medical Respite. So while people are in respite, they also get wraparound services. We have a peer support worker who also serves as the case manager. The last 2 years, 50% of the people who have been dismissed from medical respite have not gone back to the streets. That's a really good number, right? That
Wow.
you can't,
That's,
and
yeah.
right. And one of the things I told, the city council, I said, you guys are doing this the wrong way. You're trying to fix the problem by just ballooning everybody and doing everybody the same way. And what we do in medical respite is the care is individualized to literally every single person. If the person needs a daily wound care, they have daily wound care. If they need daily antibiotics, they have daily antibiotics. So it's really, we look at them and their needs and tailor the care to them. We also do the same thing with our case management services. And our Virginia, our case manager, works with each person starting the day they come in and start like, what is it you want to do when you're dismissed? If they say, I want to go back to the streets, that's fine, right? Then that's fine. We'll facilitate that. Good story. I'm going to tell you the story about this guy. So Popeye, when I met him in February, he had severe frostbite, and I was the one who took him to the hospital, and I started talking to him. I'm like, Popeye, you're going to need amputations of all of your toes. And I said, when you get dismissed from the hospital, then you can come to our medical respite. We'll let you heal. And he's like, young lady, because he called everybody young lady, I was born in the hills. I've lived in the hills all my life. I'm going back to the hills. I said, okay. He was born in Arkansas in the hills and had been in prison or in the hills his entire life. That was all he knew. So I said, that's no problem. Will you come to us to heal? And he said, yeah, I will. So he got out of the hospital in early March. Mid-April, one of my nurses was doing his wound care, and he said, I don't think I'd mind going to an apartment. And so we're like, okay, because up to then, he had said he did not know how to live anywhere except for outside. So fair, right? So we started working on a plan to get him housed, but he was not going to a shelter. He was not going to transitional housing. He would only go to his own apartment or back to the streets. Well, when it was time to dismiss him, we had to dismiss him back to the streets with the agreement that he would follow up with us and we would know where he was. 2 weeks after he was dismissed, he got his housing voucher and he got housed the next day. This is a guy who in February said, I never need to live inside. And he's still living in his apartment. He follows up with us for dental. He follows up with us for his ortho because we have a relationship with Hanger Orthotics. And we got his orthotics for his shoes. I mean, that's a win to us. Yes, he was dismissed back to the streets, but we showed him that consistency and that, just because you have been homeless your entire life, you don't have to go back there if you don't want to, right? He didn't know any better. He told me one time, he goes, you know what? You don't miss what you've never had.
Beautiful.
Yeah. Yeah.
Yeah.
Yeah. Yeah.
Thank you for sharing that story of Popeye and the story of Johnny. It kind of brings to life this work that we're engaged in. You have a incredibly robust program that is coming up on its 10th anniversary. Could you tell our listenership a little bit about the lessons learned? Like what have you learned from this journey that you would point to as, just three or four things that if you were going to do it over again, this was critical or this was important.
So I think one of the biggest things that I've learned, and we've always done this, is let the streets guide you, right? In the directions you're going, both physically and as an organization. Letting the streets guide our needs has been really important for our patients and for us. I don't make decisions based on what I think is most important. I make decisions based on the needs of the patients that we're serving, right? The other thing is lean on the people around you, whether that's the patients, or your volunteers or your staff. Our patients, by us meeting them where they are, they place an immense trust in us, and us going into the streets creates a vulnerability in us that earns more trust from them. I keep it real. I keep it real. If I have somebody that says to me, well, you know, am I going to be able to do such and such? I'm going to say, I don't know. And it's okay to say, I don't know. When we say, okay, we're going to come see you on Thursday, people would sometimes get angry and be like, well, you were supposed to be here. And I was like, we don't tell people times. We don't make promises. Don't make promises you can't keep. One of the things I learned early on is that if you're going to start doing something, me as the founder, better be prepared to follow up on it. So I had a volunteer who wanted to start coming out regularly. He was a physician and he wanted his own street night. Well, at that point, we had one street night and one clinic night. And I was like, okay, well, we can do that. And we worked it around his schedule. And he did it for a month, and then he started making other plans. That meant that I had to do that because we had already started telling patients that we were going to be there, right? And so if you're the founder of this organization, you have to be all in. You have to be prepared for those things to happen. When COVID hit, I lost almost every volunteer I had, not because they didn't want to come out, because most of my volunteers at that time were working full time. Some of them in ICUs and COVID units, some of them taking care of fragile elderly people. So they didn't want to either bring COVID to the streets or take COVID back to their patients. They were really limiting their contact. And so during COVID, now we weren't doing 9 clinics a week like we are now, because I would probably be dead. But I think at that time, I think we had 5 clinics a week. And I was doing them all as the provider. My husband was driving the bus. Cheryl, who was my right arm, was with me every night. One of our nurses, who was a volunteer, was with us every night. And you have to be prepared for that if you are founding an organization like that. It is your baby. It's a child, literally.
Fantastic. This has been so enjoyable, and I've so appreciated your forthrightness and your honesty in talking about the work, and you live and breathe it, and that just comes through in the way you've been talking about this. We're coming down to our last 2 questions,
Okay.
and one is, if you could give one piece of advice to make the world a better place, what would it be?
Grace. Give yourself grace and give others grace in everything that you do and everything that they do.
Thank you. Huge and helpful advice. And then, KK, how can our listeners connect with you?
Sure. So we have a website, of course, right? Care Beyond the Boulevard, carebeyondtheboulevard.org. And that really tells the story of what we've got going on. It has our calendar. It shows what we're doing every day. And then we have a Facebook page that's quite active, and it's Care Beyond the Boulevard at Facebook. We have a TikTok. We're trying to get our TikTok going.
Yeah.
And so those are the places where they can connect with us. And you know what? Anyone can email me at any time. It's Janelle, JAYNELL, at carebeyondtheboulevard.org.
Fantastic. KK, this has been a delightful interview. I've so enjoyed our time together. Thank you for being on our show.
Thanks for having me.
The opinions expressed in this podcast are those of the individuals included and are not representative of the opinions of the Street Medicine Institute or the Street Medicine Institute Student Coalition. Do not use this podcast as medical advice, and instead see your own provider for medical care.